Good day. This is Andy speaking, welcoming you to watch a 2025 update to the Expert Field Medical Badge Testing Instructional videos. This video depicts the Tactical Casualty Combat Care Task 3 Respiration Management. This task is usually performed multiple times during a 105-minute continuous lane. However, because specific wound patterns and locations are selected by hosting units, the task in this video is shown in a standalone format. The video was recorded in September 2025 and tasks are performed to the June 2024 EFMB standards recorded in MEDCoE pamphlet 350-10. A special thanks to the lane graders for demonstrating this task and filming the video. These videos were filmed to serve as candidate study guides during local training and testing and are not affiliated with the EFMB Test Control Office.
Alright, good morning. I'm Sergeant Taboo. With me, I have my demonstrator, Sergeant Jishnu. Today we will be demonstrating T3 of EFMB, which is Respiration Management. Your first step in respiration management is to take BSI precautions. After ensuring you have taken body substance isolation precautions, you will then begin to expose your casualty. After exposing your casualty, you will begin to visually and manually rake for any penetrating thoracic trauma. Once you have found penetrating thoracic trauma, you will then begin to treat the penetration with an occlusive dressing. To treat with an occlusive dressing, you will first wipe the wound with gauze. Freeing the wound of any clots or debris that may obstruct the occlusive dressing. After wiping the wound with gauze, you will then apply an occlusive dressing upon exhalation. In this step, the candidate must state they are applying the occlusive dressing upon exhalation.
Waiting for exhalation. Exhale, exhale, exhale.
After applying the occlusive dressing, the candidate must finish their rake and then log roll the casualty onto their knees to assess the posterior. It is important to note that at this step, you may place the casualty onto a litter and into their hypothermia prevention kit. You may also place the casualty in a pelvic binder if it's indicated. Once you have assessed the posterior, you will expose the casualty and then begin to manually and visually rake for any penetrating thoracic trauma. Once you have found penetrating thoracic trauma, you will treat the penetrating thoracic trauma with an occlusive dressing. To treat with an occlusive dressing, you will first begin by wiping the wound with gauze. After you have wiped the wound with gauze, you will then place the occlusive dressing upon exhalation. Again, the candidate must state they are applying the occlusive dressing upon exhalation.
Wait for exhale. Exhale, exhale, exhale.
After the occlusive dressing has been applied, the candidate will place the patient back into supine position, where the next step is to reassess all previous interventions. By now, you have gone through massive hemorrhaging and airway. You will ensure that the tourniquets you've placed are still effective and that the junctional wraps that you've done are still holding. You will also make sure that your airway is still patent. After ensuring that all previous interventions are still intact, the candidate will then monitor the patient for signs and symptoms of tension pneumothorax. The candidate will get down and place the bottom of their thumbs on the bottom of the casualty's diaphragm, looking up towards their torso.
Assessing for progressive respiratory distress.
The candidate will monitor for signs and symptoms of attention pneumothorax by stating they are assessing for severe or progressive respiratory distress or severe or progressive tachypnea.
Assessing for severe progressive respiratory distress and assessing for tachypnea.
The candidate must state 2 of the 5 that are stated on MEDCoE PAM 350-10. After your candidate has assessed for signs of attention pneumothorax, your grader will state your patient is exhibiting signs of attention pneumothorax, to which the candidate will treat First, by burping the chest wound. Burping the chest seal. The first step of burping the chest seal is to peel the chest seal back about halfway, exposing the wound. You will then wipe the wound with gauze, freeing it of any clots or debris. After wiping the wound, the candidate will replace the chest seal upon exhalation.
Exhale, exhale, exhale.
You will then move directly into placing a needle chest decompression. After identifying the appropriate needle length and gauge, which is 3 1/4 inch long needle, 14 gauge, 10 or 14 gauge, the candidate will then choose the appropriate site for insertion. The appropriate sites for insertion are the second intercostal space directly above the third rib, midclavicular, or anterior axillary line directly above the sixth rib. For demonstration purposes, we will be using the second intercostal space.
Running CD placement down. Found my second intercostal space, midclavicular.
After identifying the appropriate insertion site, the candidate will then remove the needle from the safety cap, and insert the needle at a 90-degree angle to the chest wall all the way to the hub.
90 degrees. Inserting. I messed up.
After identifying the proper insertion site, the candidate will then insert the needle at a 90-degree angle to the chest, inserting the needle all the way to the hub.
Found my site. Inserting 90 degrees to the chest wall. I'm going to insert all the way to the hub.
After inserting all the way to the hub, the candidate will state they're leaving the needle in place for 10 seconds to allow air to escape.
Leave needle in place for 10 seconds and wait for audible hiss.
After leaving the needle in place for 10 seconds, they will then remove the needle, placing the needle back inside the safety cap. You will then secure the catheter to the chest using tape. That concludes all steps required for T3 respiration management.